It is my absolute pleasure to introduce our next speaker, who will be coming to us over Zoom today, Dr. Beth Mormino. So Dr. Mormino got her bachelor's with honors in neuroscience from UCLA, followed by her PhD in neuroscience at Berkeley with work under Dr. Bill Jagust. She then went to Harvard MGH, where she did her postdoctoral fellowship with Reisa, Sperling, and Keith Johnson, and really established herself as one of the absolute emerging leaders in our field of looking at early imaging biomarkers with regards to cognition and memory. And that is very well shown by the numerous awards she's received over the years. I was so impressed reading through her CV. She was the recipient of the Human Amyloid Imaging Conference Young Investigator Award, the Alzheimer's Association Young Scientist Award for Excellence in Research, the MIT Technology Review and Innovators Under 35 Award. She won the Early Career Investigator Award for the Charleston Conference on Alzheimer's Disease, and most recently the Clark Award at the Human Amyloid Imaging Conference. She has over 90 peer-reviewed primary research manuscripts and numerous review articles, editorials, and book chapters. And I can personally say that she is a superb teacher and mentor, having co-mentored a couple postdocs with her over the past few years. It is a humbling experience co-mentoring with Dr. Mormino. You really have to step up your game. And she is invited internationally to speak on her expertise in the early detection of amyloid and tau pathology in cognitively normal adults, those at risk for cognitive decline, and those with dementia and cognitive impairment. So, Dr. Mormino.
All right, I think I'm sharing. Okay, thanks, Kathleen, for that introduction. And I'd like to thank the organizers for including me in this symposium. I'm very sad to not be there in person. Ever since my 8-year-old stopped masking at school, it seems like I'm sick every 3 months now. So hopefully that's going to result in some immunity going forward. Okay, I think I'm set up here. All right, so these are, this is what I'm going to touch on today during my 30 minutes with you. So I'm going to start with a brief background on Alzheimer's disease and specifically introduce the concept of preclinical AD, which is these initial stages of pathological accumulation before symptoms are present. I'm then going to show some recent data that we've been working on characterizing patterns of tau PET uptake throughout cortex in our aging cohorts. And importantly for this symposium, these patterns really nicely align with many of the key regions involved with successful memory. And then lastly, I'm going to show some data looking at AD risk factors and age to fMRI metrics of cortical reinstatement that we've been working on here in our Stanford Aging and Memory study. So as I'm sure everyone in this audience is aware of, Alzheimer's disease dementia is incredibly common in older individuals above age 65. It's a progressive neurodegenerative disease that typically begins with episodic memory impairment, but not always. And as the disease progresses, it ends with, it incorporates a loss of independence across day-to-day activities. Pathologically, Alzheimer's disease is defined by the presence of these hallmark pathologies shown in this slide. So specifically the amyloid plaques. So here's a schematic from Thal, and then also the tau neurofibrillary tangles shown here in this work by Brock and Brock. So we have an extensive postmortem literature that has characterized these hallmark pathologies in terms of their prevalence and their spatial distributions. Interestingly, the amyloid plaques, as shown here, even in its initial stages, they tend to be widely spread out throughout cortex. So that's shown here in this black, in these black regions, whereas the deposition of tau tangles seems much more focal and nuanced. So from Braak staging, we know that it typically begins in the entorhinal cortex. That actually probably happens in midlife. And from there, it spreads into the hippocampus and adjacent limbic regions before eventually becoming distributed throughout cortex, shown in this later depiction by Braak. So in addition to what we know from the postmortem literature, now for nearly 20 years, we've been able to measure amyloid plaques using PET. So here's one example of a PET scan here. And for about 10 years now, we've been able to measure the tau tangles using PET. So here's two examples, a more focal pattern of uptake, and then a more distributed pattern in this more advanced individual. So the ability and integration of these in vivo markers have really led into a research framework where we can start to measure these key events that we know are important for Alzheimer's disease in vivo in humans and follow this over time to get a sense of disease progression. So for example, the trajectory I'm showing here depicts the sequence that the sequence suggested from the amyloid hypothesis of AD. So in this hypothesized sequence, it stated that amyloid accumulation is this early initiating event that somehow leads to the spread of tau, and eventually we get neuronal dysfunction and degeneration. And then on top of these biological changes, I've superimposed where clinical stages of this disease are expected to fall. So in the later stages, that's where we would expect to see overt dementia, so loss of these daily activities, the functional abilities. Before the stage of dementia, we know there's this more specific cognitive impairment that can happen. This is called mild cognitive impairment. So here there's objective impairments, but there's no loss of functional activities yet at that point. And interestingly, we know that even among clinically normal, unimpaired older adults, this is when these initial pathologies begin. So amyloid and tau accumulation begin well before any sort of objective cognitive impairment is detected. So this is quite an interesting group. One, we want to, they're not detected clinically. They're really a biomarker-defined construct. It gives us an opportunity to understand, what are the initial consequences of this pathology before widespread damage has occurred. It also gives us an opportunity for early intervention. So we could test, whether or not directly targeting amyloid and tau or other processes in this population can prevent these downstream changes that are closely linked with objective impairment and dementia. I'll also note that we can measure these proteins, both amyloid and tau, using cerebrospinal fluid, so CSF, after a lumbar puncture. I'm going to show some data on this when I get to our aging study. We lose the spatial resolution with these biofluid measures, but that is another tool which allows us to characterize amyloid and tau. So the fact that these pathologies begin amongst clinically unimpaired individuals, this is a concept that has been labeled preclinical AD. So effectively just the presence of this pathology, no clinical symptoms. This is just a term to describe it. It's a framework to work with. And now we've been able to measure these pathologies. We've been able to study these individuals and also see what happens to them over time. So we have a pretty good idea of what that data looks like at this point. And it's very interesting in that we know that these folks that have this biomarker evidence certainly show greater risk of progression down the line. Many individuals will have this pathology and they'll remain clinically unimpaired for very long follow-up periods. So even though we call this preclinical AD, the actual interpretation of this group, it's really unclear. There's some risk associated with it. But it really highlights actually our lack of understanding of the mechanisms that really drive progression to either dementia, shown in this pathway, or mechanisms that promote resilience, so resilience to this initial pathology. So this is obviously really important. These are important targets and an important focus of our research program, and I think of high interest to the field in general. What are actually the mechanisms that promote resilience or impairment, even in the face of AD pathology? Okay, so I've defined this concept of preclinical AD, and here are some slides to just highlight actually how common it is amongst clinically unimpaired older individuals. So here's a meta-analysis that describes the prevalence of amyloid positivity, that's shown on the y-axis, as a function of both age and ApoE genotype. So those two factors are the strongest predictors of amyloid positivity. And from this plot, you can see that among 70-year-olds, anywhere from 10% to 50% or so will end up having this evidence of abnormal amyloid in their brain, depending on their genotype level. So we know that the E4s have greater risk compared to the 3s, and then the E2s tend to have reduced risk of this positivity. But again, this is very common, and this is going to be present in all of our aging cohorts to varying degrees. And then among those that are amyloid positive, we expect, or so far what we've noticed with the tau PET data is about 1/3 of them will also have some form of tau PET elevations. So here I'm showing 3 different examples of individual research participants that we've studied that kind of summarize the overall patterns that we've been noticing. So here's one participant who, this is the amyloid scan, so it's broadly positive, as expected for the amyloid side of things. The tau scan, it's mostly cool colors, suggesting a lack of uptake throughout the cortex. The one exception in this case is the striatum. This is actually an issue with the PET ligands. There tends to be this non-specific binding in the striatum that's not thought to reflect tau tangles. But other than that, it's a very low scan. So this is about 2/3 of amyloid positive folks will fall into this bucket. And then the remaining third will have profiles that look like this. So this first case, again, a very broadly amyloid positive scan. But then in their medial temporal lobe, they have this kind of focal tau uptake in the medial temporal lobe, and then their cortex is relatively spared beyond the medial temporal lobe. And then here's a case, this is again a clinically unimpaired individual, same thing with the amyloid scan. The tau, we do see some focal uptake in the medial temporal lobe. And then here we actually also see this cortical uptake. In this case, it's in kind of the lateral parietal lobes bilaterally. So this is what we've been noting so far. I'm going to talk in detail about these cortical representations, since there seems to be a lot of heterogeneity actually in this once we get to cortex that I'll describe for you. And now here, this is showing how the range of tau PET values within clinically unimpaired subjects compared to impaired subjects. So we know that the accumulation starts early, but this is really to highlight, that it's an early signal, and the range is quite reduced compared to in impaired groups. So these are our clinically unimpaired individuals separated by amyloid status. This is medial temporal lobe tau is plotted on the y-axis, and we definitely see this group level increase in the medial temporal lobe, suggesting this early focal signal. However, compared to the MCI and dementia groups, you can tell that the group level difference, it's much less than what we see in impairment. So I think this is interesting. It really highlights we're capturing an initial early process. This is just a contrast of what these 2 representative scans might look like: a normal control with the focal uptake, and then somebody with this more widespread pattern. And again, we're just very interested in this transition. What drives this initial stage and the progression to this kind of widespread high magnitude signal. So given that, based on both the postmortem literature and also the observations from the tau PET side, one very obvious thing to ask is, does this medial temporal lobe tau PET signal does it explain individual differences in cognitive aging, in memory amongst our aging cohorts, given that a decent chunk of folks will have this signal. So a number of cohorts have really kind of focused on this for the last 5 years or so, and have shown across the board that, yes, this is the case. If you have a little bit of tau signal in your medial temporal lobe, you tend to be slightly lower on memory. So that's shown here for the Harvard cohort and also the Berkeley cohort. In both cases, intrarenal tau is plotted on the x-axis against a memory measure on the y-axis. One thing to note, these scores these are still within the normal range. So this is well above what we would consider MCI, but it does show that this subtle elevation in the medial temporal lobe with respect to this tau signal does align with subtle differences within the normal range of memory performance. And again, this has been shown now over and over again across multiple aging cohorts. So building on this, we've been quite interested in these patterns of tau deposition throughout cortex. So we expect there to be some signal in the medial temporal lobe, but it's quite unclear what to expect within the cortex during these initial stages. So we were interested in quantifying that. And another layer to this is whether or not these patterns that we find within cortex, if they exist, are they actually consistent across individuals? So from the postmortem literature alone, we think of Braak staging, we tend to think of a sequence that begins within the medial temporal lobe before they're spread into these cortical regions and later Braak staging. So in that case, it would be first you have the medial temporal lobe and then you have the cortex. However, the staging that happens in postmortem examination, it's quite sparse. It's usually limited to a few samples, and oftentimes only one hemisphere is selected. So we actually don't have a really good understanding of the exact patterns that happen throughout the whole brain early on. So these are some group level maps now. So it's unlike postmortem sampling where it's very difficult to look at the whole brain. With PET and with these imaging measures, it's quite easy for us to do a sweep of the entire brain. And so here's a couple. These are some analyses that we've led within this A4 cohort. I'm going to talk a little bit more about later. And here are some work from Berkeley and Wisconsin, setting up the same type of contrast. And here, the question is simply at the group level amongst amyloid positive, clinically unimpaired individuals, where is tau elevated compared to amyloid negative individuals? And so that's what these are statistical maps showing those elevations. And so as expected, we definitely see this medial temporal lobe signal, reflective of these early Braak stages, but a number of additional regions throughout cortex also seem to be implicated in these clinically unimpaired individuals. One of the most striking things for me when we first started looking at the tau PET data was the involvement of VTC. So it seems like at the group level, we really have a wide area of VTC bilaterally that is involved at the group level amongst amyloid positive clinically unimpaired individuals. In addition to VTC, we see involvement of the posterior cingulate and precuneus, and also inferior parietal, mostly in the angular gyrus. And this has been also a consistent finding across multiple cohorts. So what I just showed you is like these group level maps, summing everybody together and looking at these patterns. Within this, as we've been collecting this data, now for a decade, it's been very striking in how much heterogeneity there actually is when you look at the individual scans. So here, this is some data that we've collected locally in our Stanford cohorts. But here's two example cases. So this case would be, I think what you'd expect from Braak staging, some focal medial temporal lobe uptake, relative sparing of cortex. But here we see kind of a different pattern. So we see that we have this lateral temporal involvement and some ventral temporal involvement, and then a relative sparing of the medial temporal lobe. So these kind of counterexamples suggest that, there might be mechanisms that drive cortical tau, and that's not necessarily dependent on the presence of medial temporal lobe tau. So that's a little bit against kind of the general Braak staging framework. And then when you start digging into the cortical patterns as well, you notice a tremendous amount of variability in where this deposition is happening. So in the group level maps, as I noted, one of the most striking things is this kind of broad involvement of VTC, but it seems as though that's being averaged across like different focal hotspots across individuals. So here are two different examples of folks that have this kind of early VTC uptake. In this case, it's a more right predominant compared to left and a more posterior a pattern. And then the opposite is happening in this second case. It's left with actually no involvement of the right at this thresholding and much more anterior. So these case examples really highlight that once we get beyond the medial temporal lobe, the specific deposition patterns can vary quite a bit across individuals. So we wanted to quantify this more formally. We were noticing this in the individual cases, but it's quite difficult to do with these smaller cohort studies because, as I noted, only 30% of normals will be amyloid positive, and of the 30%, only a third or so will show this tau uptake. So with our local studies, we're really restricted to get at the ability to characterize, any sort of heterogeneity that might exist. So we had been holding off on it. And then during COVID, the A4 study, which is it's a clinical trial that's targeting clinically unimpaired individuals to treat with an anti-amyloid therapy. The whole point of this study is to build up a big cohort of amyloid positive individuals for this drug. And as part of this, they did a tau PET sub-study where they specifically focused in on amyloid positive clinically unimpaired folks. So they were really able to enrich their tau PET data set. So here there was 400 or so amyloid positives that underwent a tau PET scan. So we took this opportunity to dig into this huge sample of characterized clinically unimpaired individuals and characterize this signal. So I'm going to talk about the details of how we defined this cortical group. But overall, what we found, as expected, about 60% or so were tau negative of this group. 30% or so had this medial temporal lobe signal. And then I'll tell you how we defined them, but we found about 9% or so that had these sort of cortical patterns that we were able to dig into further. And this is so we defined the cortical pattern with two different concepts. So we were interested in this idea of a mismatch between the medial temporal lobe and cortex, with this idea that perhaps there's factors that drive cortical deposition that aren't dependent on the medial temporal lobe. So to identify those cases, we did essentially a residual approach where we looked at the association between medial temporal lobe tau in relation to a number of cortical regions, and just simply asked, are there subjects that seem to have more cortical deposition than expected by the medial temporal lobe alone. So that's depicted here. So you can see this is an example number 6 who has some elevations in the medial temporal lobe, but their left lateral temporal seems to be much higher than expected. This is what their scan looks like. So they do in fact have this kind of left predominant presentation. This is the same type of plot, but with the other hemisphere. And here, number 3 is an example of somebody that has greater than expected cortical uptake compared to their medial temporal lobe signal alone. Their scan is shown here. And then the other theme we were interested in is just this asymmetry. So actually these cases would meet both criteria. They have higher cortical patterns than expected and also an asymmetric presentation. So we were quite distributed in our approach and just asked about these two different features: higher cortical signal and/or asymmetry, and we just called that cortically positive. So we were able to find this 9%, which amounted to about 36 participants that met this criteria. And then of those 36, we tried to understand if there was some substructure within this data, and if there was evidence of different spatial patterns within these cortically positive, clinically unimpaired individuals. So the results of this are shown here. So for comparison, these are maps just showing the tau negative group. On the surface, there's very little uptake, mostly cool colors. Here's the focal medial temporal lobe positive plus group. So we just have some signal in the medial temporal lobe that kind of extends to ventral temporal cortex. And then here's the group of 36 now divided into these spatial subtypes. And we did essentially find a pattern that matched our observations from the single scan data that we had been collecting. So one, we do have this kind of asymmetrical left that seems to be predominant in the VTC. So that's subtype is shown here. You can see the VTC is much more involved with relative sparing of the right side. Then we find the opposite. So we have this right predominant presentation. So the right VTC is involved with relative sparing. And then interestingly, we also have this kind of precuneus predominant subtype too, where it seems like even though there's some involvement with the VTC, the precuneus is really jumping ahead in this subtype. So I'm going to transition away from the tau PET patterns and into the reinstatement metrics, but the thing that is very exciting to us and is just the degree to which these tau PET maps map on to these regions that are key for recollection and reinstatement, which we've heard a lot about today. So these are the group level maps that I've shown you with the tau PET side, and you could see this really nice alignment with these kind of core nodes that are important for recollection. I'm going to talk about this category, or we're going to talk a lot about reinstatement when I get to the SAMS data that's coming. But we also know that these posterior regions are quite important for these category-specific reinstatement processes. And interestingly, these different subtypes, you could hypothesize might impact these processes in a different way based on their alignment of the tau PET data. Okay, so I'm going to transition now away from the tau PET characterization and cortex to our aging cohort. So we've been working with what we call the Stanford Aging and Memory Study, SAMS. So this is a large baseline study of that focused in on clinically normal, unimpaired older adults. So everybody is a CDR 0 and also determined to be normal via clinical consensus that used a neuropsych battery. This is data that was collected between 2014 and 2020. And yeah, we collected a little over 200 individuals. There's 3 visits as part of this study. So for the first visit, individuals did neuropsych blood draw. Second visit, they did a visual associative memory paradigm that I'm going to talk through. And then in visit 3, they did both a lumbar puncture so we can assess these AD biomarkers and also a 7T MRI scan. So I'm going to present data both on the fMRI side and also on the lumbar puncture side. We unfortunately don't have tau PET data on this full cohort. We did do a small sub-study where we added on tau PET mid-study, and we do find that the tau PET signal is quite correlated with the CSF metric of p-tau, but again, we obviously lose the spatial resolution. So here's what the biomarker profiles look like within our cohort. We only have the CSF data available on 153 out of the 212. As expected, so this is the CSF amyloid measure. Here are the 2 modes that we expect, these kind of bimodal distributions. We have about 25% of our population falls in what we consider this amyloid positive cluster. Here's the association between amyloid and p-tau. So this amyloid ratio, these are the amyloid positive folks, the same cluster here. They tend to have some evidence of elevated p-tau levels, but again, there's a lot of variability. There's a lot of amyloid positive normals that have very, very low signal. If we were to place a cutoff on top of this distribution, we would estimate, again, about 1/3 of the sample are positive. So it's really just this small sample. And unfortunately, that only amounts to about 10 subjects or so. So this is always a limitation with our aging cohorts, that you have to characterize a large number of subjects to find these different biomarker-defined groups. So I'm not going to talk in depth about reinstatement. I mean, we've heard a lot about that already in the symposium, but this is our primary metric that we're interested in, the reinstatement of encoding activity during retrieval. And just noting that, even though we don't have this tau PET data, we do have some hypotheses that these early AD processes, should be or potentially influence this ability to reinstate these activity patterns. So here's the visual associative memory paradigm that we use in SAMS. during the study phase, individuals are asked to encode visual pairs. So there's a word paired with either a famous face or a famous scene. Excuse me. And then during the test, the participant is presented with the word cue and asked to recall the visual pair. So for here, they would be recalling the Golden Gate Bridge if they remembered that. And then our primary measure is this reinstatement strength. So effectively, classifiers trained on the encoding data to define patterns associated with our two categories, spaces and places. And then at each trial, we can get an estimate of the degree to which the patterns of activation mimic the categories as defined during encoding data. So we get trial level reinstatement strength across all the test trials. Okay, so here are what the general behavior of this reinstatement measure. So here, trial level reinstatement is plotted on the y-axis with hippocampal activation on the x-axis. And we can see there's this relation as expected. We know that this process should be hippocampal dependent. So as the hippocampus is increasing, so does reinstatement strength. This measure is also related with likelihood that trial was actually successfully recalled. So that's shown here as reinstatement strength at the trial level increases, the likelihood of a successful memory at that trial also increases. So this is within the trial, within individual trial data. And then we can also, so each participant has all these different reinstatement strengths across trials. We can average this to give an overall measure of reinstatement strength for a given individual. And excitingly, this reinstatement strength measure nicely predicts overall memory performance, both in the scanner shown here, and also on a general delayed recall composite measure from the neuropsych testing. I need to kind of go a little faster because I'm running out of time. So here, what I previously showed you, the last slide was focused on the VTC ROI. So here, this has now been replicated to look at regions throughout the more general recollection network. And suffice it to say that the patterns are generally the same with these reinstatement measures, both at the trial level and also across trials. And now, the final thing we're interested in is, does this actually relate to early AD and aging? So here are the two reinstatement measures that I'm going to focus on, VTC here, and also an average across those DMN regions that I went through quite quickly. In both cases, this lower reinstatement strength is reduced as a function of chronological age, and it's a quite strong relationship. However, when we look at the p-tau distribution, so we do see a hint of a relationship with p-tau and VTC. So that's shown here. So if you tend to be on the higher p-tau levels, your VTC reinstatement is lower, but this is just a trend level. And importantly, we see a lot of folks that are fine on their p-tau levels that have low reinstatement. So we don't actually see a very strong relationship between our p-tau measure and reinstatement. So given that, we thought, maybe we should look at some other, AD markers to see what might be driving that low reinstatement. So we looked at ApoE, and generally we think of ApoE as being a proxy and an important predictor of amyloid, as shown here. So this is the data within SAMS. We typically expect, so a lower ratio is more amyloid positivity. And we do tend to see that if you're ApoE4 positive, you tend to have a lower ratio. But there is a lot of variability. It's not a one-to-one marker. And we also know that ApoE is involved with many broad effects beyond the canonical AD pathway. And so that gave us this opportunity to probe whether this might be driving some of this low VTC reinstatements among people that are not elevated on tau. And that's in fact what we find. So we find that if you're an ApoE4 carrier, you have significantly lower reinstatement. This is across all subjects. And even if you exclude all the amyloid positive subjects and focus in on these amyloid negatives, you still see that E4 is a strong predictor of this VTC reinstatement. So this is a busy slide, but just to conclude, to pull all the data together from SAMS. So we kind of set out with this hypothesis that this VTC reinstatement should be related to p-tau, given these patterns of deposition with tau PET. We didn't find that. We found there was a loose association between the two. But interestingly, both independently predict individual differences in memory. So we have these strong associations between VTC and memory performance. We see the same with p-tau. When we put both in the model, they both explain independent components of this. And in fact, when both are modeled, we completely mediate the relationship between age and memory. So it seems like they both are strengthening our prediction of memory performance, even though they aren't directly related strongly to each other. And finally, we do have these upstream paths as well, such that both age and ApoE seem to be quite important for VTC reinstatement, and also for this canonical AD pathway. So this is really showing us that we have these kind of multiple pathways influencing memory within our sample. So I will conclude very quickly. I know I'm a few minutes over. So I've told you that we have multiple trajectories of cortical tau detectable early on in AD amongst clinically unimpaired individuals. And interestingly, these regions do overlap quite a bit with the regions that are critical for visual associative memory performance. We do, just as other studies have noted, about 7% or so of our aging population has this amyloid positive, T positive profile. We found an unclear association between our p-tau measure and our cortical reinstatement measure. However, both of them independently predicted individual differences in memory. We also found, so beyond this kind of canonical AD pathway, the strongest predictors of cortical reinstatement were both chronological age and ApoE, even among amyloid negative individuals. And the final statement is just that, this really highlights that multiple pathways, are influencing this memory change in aging. So I will skip those, and I will end with a thank you for your attention. I want to acknowledge the Stanford Aging Memory Study, both the co-investigators and also the Stanford ADRC, which we lean on quite heavily for a lot of our biomarker work within SAMS. And I also want to acknowledge Ali Trell, who led all the analyses related to cortical reinstatement with SAMS, and then Christina Young, who led all the analyses on the tau PET side describing heterogeneity. Thank you. I'm sorry for going over.
So, questions within the room? Nicole?
Hi, it's Nicole Rust here. Really beautiful work, really gorgeous to see, really carefully done work on these biomarkers. I'm curious to get your thoughts on, so as a neurophysiologist, I can completely appreciate, the need to establish correlation before going for causation. And I think causation in this field has been the tricky thing, right? So the predominant hypothesis, which you put forth, is that amyloid and tau are causally related to Alzheimer's. But there are also theories floating around out there that they might be the consequence of Alzheimer's, but not necessarily the cause. And so I'm just curious to hear your thoughts about, conceptually, what does the map look like from taking these sorts of studies from the level of correlation, which you've just shown us, like what is the correlation between dysfunction and these biomarkers, and taking this into the realm of causation? What is causing this to happen? What causal role does amyloid or tau play in memory dysfunction?
Yeah, I think for humans, one approach is a clinical trial, so in the Alzheimer's space, that hasn't panned out. So this idea of removing amyloid, has not led to a direct benefit on things like memory or cognition or function. But I do think that's the answer to going from correlations to causality, is to actually test, these processes in the context of a clinical trial. One thing that keeps coming up is that given that Alzheimer's disease, the pathological processes seem to be spread out over decades. A criticism of some of the trial design is that, you can't wait until somebody has dementia to treat, to intervene on processes that are happening, decades before. So I think these prevention trials where folks are getting targeted very early will help get at the causality piece that you're asking about. They're going to test this hypothesis that either amyloid and or tau or some sort of combination is actually causally linked. So I think that is what we have to do as a field. I don't feel strongly that I don't necessarily know if that's going to work out. It seems like so far these markers, amyloid and tau, biomarkers are a very strong prognostic tool. So it's, even if these processes are not the direct, cause of impairment, they give us this kind of in vivo opportunity to capture people that are in a pathological state or perhaps entering a pathological state. So it seems like an ideal framework to use these biomarkers to identify, early populations and then to test various mechanistic pathways on these folks, not necessarily just amyloid and tau. Now it seems like at least the trials that are in phase 3 are highly skewed towards amyloid and tau approaches, but it seems like it would be naive to only focus on amyloid and tau, given that there's many other mechanisms that can be driving the actual impairment. But so far, the amyloid and tau markers, they do tend to give a good sense of prognostics of, the correlation part that you brought up.
Hi, Beth. It's Marion Buckwalter. Great talk. I really enjoyed it. It's really fascinating to me how these cortical patterns of tau really differ. And I apologize if you talked about this. Maybe I missed it. I'm wondering, does it relate at all to the patterns of amyloid deposition? So these are all amyloid positive people, but have you looked for correlations with more amyloid and more tau, or are they really truly unrelated? The second question is, do we know if we ever see tau without amyloid? And if you do, is it any different in patterns?
Yeah, so the first question, there really seems to be no relationship between the spatial distribution of amyloid plaques and tau tangles. So the amyloid plaque signal really seems to be everywhere. And so, yeah, we've looked at this a number of times, and it's a very global signal on the amyloid plaque side. There could be differences. So, I didn't go through the different stages of amyloid, but, there are these oligomers and these monomers. There's many steps of amyloid processing before you actually get to a plaque. So, we can't measure that with these PET scans. So we're not able to rule that possibility out, but the plaques themselves are definitely not co-local with the tangle side of things. It seems as though there's a different process. The processes driving tangles, it seems like it's more linked to spread within certain networks as opposed to the amyloid side. So I guess that's your first question. We definitely do not see at the PET level any sort of spatial correlation between amyloid PET and tau PET. The second question, so in terms of AD like tau, so the 3R, 4R aggregations that we see in the tau tangles. So we do see tangles, in the brainstem and in entorhinal cortex, and that is kind of thought to be amyloid independent. And begins much earlier than this kind of amyloid correlated process late in life. We also see there's this concept called PART, which stands for primary age-related tauopathy. And that has to do with specifically amyloid negative folks that have some spread from entorhinal into the hippocampus and maybe a little bit into IT. So that is a construct too. It might be a continuation of this kind of age-related entorhinal signal, or it might be a distinct concept. And then every once in a while, so there was a recent publication about this, and we've seen this at least in one case from our from the Stanford ADRC, every once in a while we will get an amyloid negative AD or dementia patient that has a very high tau PET scan. But I would say that that's probably about 1% or so of our amyloid positive impaired folks. And I think the idea there is that there's kind of something wrong with the amyloid scan. That's one possibility. Another possibility is there's forms of amyloid aggregation that don't result in plaques. So they wouldn't be detected with the PET scan. But they seem very, very rare, that precise phenotype of having overt AD-like tau detected with PET in the context of an amyloid negative biomarker profile.
Great. Thank you, Beth, for a wonderful presentation, outstanding talk. And yes, you can tell from the questions, a perfect sort of transition between the basic science to the applied clinical science, given the nature of the discussion we just had. We're going to reconvene in 30 minutes at 3:30 for the fireside chat between Carol Ho and Tony Wascori, where I'm sure many of these questions that have just come up given Beth's talk will be taken up amongst other topics. So thank you again, Beth, for the great presentation.